All right, airway physiology and capnography. Got to briefly go back and look at the physiology of airway, and that's content that you should be pretty well versed on at this point. But just a quick reminder, because it is important to be able to differentiate between upper and lower airway structures, because assessment when it comes to injury or illness related to airway could have key assessment findings based on where it is, right? When you talk about sounds, airway sounds, when you talk about fluid being in the airway versus fluid being in the lower lobes, airway edema, whether you've got edema or bronchoconstriction in the lower airway, or you've got edema or laryngoconstriction in the upper airway, so on and so forth. It's also very important to know your upper airway structures in relation to landmarks when you're doing your advanced airway. A couple of the things that FISDEP's going to want to know that you know is your tools that you use for advanced airway. When you use your straight blade versus your curved blade, and so on and so forth. Of course, you know that your tongue is one of the most common causes of airway obstruction in the unresponsive patient. If you hear snoring in an unresponsive patient or a target patient, most likely it is caused by what? The tongue. What do? What? Head, tail, chin lift, or whatever. We do a manual airway maneuver, right? We do a manual airway maneuver. Also very important when it comes to airway management is to remember your basics. You always do your basic maneuvers first. You always do your manual airway opening. And then you use your basic adjuncts, your OPA or your NPA, and you need to know the contraindications for those as well. Are there any questions about the airway, the structures of the airway, the upper or the lower airway? Because we're going to move on, if not. All right. So ventilation and respiration. What's the difference in ventilation and respiration? All right, so ventilation is what? Mechanical movement of air, whereas respiration is what? Gas exchange, or the chemical function of the respiratory system. With ventilation, you have to have several key factors in order to have a good, efficient, productive ventilation. Number one is the tubes can't be clogged up, right? You can't have a kink or a plug in the plumbing. Your airways have got to be open. Another one is your chest wall, because when you're breathing in, your chest wall, it expands to create what type of pressure? Negative pressure. It creates negative pressure, a vacuum effect to bring in the air. You've also got to have intact lungs, because if you've got holes in your lungs, then that air is going to go where? Into the pleural cavity, right? Into the intrathoracic space. You get issues such as a pneumothorax, and you continue to try to force air down, and you continue to fill up the intrathoracic space. What occurs? Tension pneumothorax, right? Tension pneumothorax, which causes collapsed lung, which causes mediastinal shift, which causes tracheal deviation, because your trachea is attached to all those things that run down the middle of your chest, and when they start shifting over. But also, remember this, remember the function or the critical role that the increasing intrathoracic pressure will play as far as with breathing, airway compromise, and also with cardiac compromise. What happens to the structures as you start developing a tension pneumothorax and you start really increasing the intrathoracic pressure? Alright, so you put pressure on your heart, so that impedes the ability for your heart to expand and contract. You also do what?
They're being crushed.
Okay, and they are. They're being crushed, but when you start getting that increasing pressure, and think of like on your pulmonary vasculature, if you start putting pressure on your PA and your pulmonary vein, what's going to happen to blood flow? Right, it's going to start impeding that blood flow, right? And so that would be one form of obstructive shock, is you're starting to have that impeding blood flow because of the increasing pressure.
That would be like compartment syndrome, right?
No, not compartment syndrome. Compartment syndrome is going to reflect more on skeletal muscle.
Okay.
And the tissue surrounding skeletal muscle. All right? So, of course, with ventilation, you've got your inspiration and your expiration. Your inspiration is active, right? Because when you're breathing in, it's requiring energy to bring in that oxygen. It's requiring the body to create a negative pressure to overcome the equilibrium between atmospheric pressure and intra-body pressure, whatever the term is there I'm looking for. Expiration. So you breathe in, your lungs, we know that they're elastic, and they start filling. And what happens whenever your lungs hit that capacity?
It triggers your brain to put in.
Right. It triggers your brain through which reflex? The Herring-Brewer reflex. It says, hey, we've got too much air, or we've got just enough air. We don't need to continue to expand, so let's relax. What do we know about an elastic structure that expands? When you release it, what happens? Right. So the more it feels, the better it's going to come out. But is that an active or passive process? It's passive. It's certainly passive. All right. Another aspect of good ventilation is an intact neurosystem. What is your main respiratory control center? The medulla is your main respiratory center, and then you've got the pons. And so they're in constant communication. We'll probably get to that in just a minute. All right. Where does gas exchange occur on the lung level? At the alveoli. And so you have gas exchange at the alveoli. Then the blood picks up that oxygen and takes it to where you have internal respiration, which is on the cellular level. All right. So remember your partial pressures. That's the pressure exerted by each gas component of a gas mixture. We're also going to be looking at partial pressures when we talk about end-tidal CO2, or your PET CO2, right? Technically, oxygen is 20.84, so we say it's 21%. Anytime that we apply supplemental oxygen, that's what we're trying to increase, right? What is that term whenever I place supplemental oxygen on somebody? What is that term when I talk about the amount of oxygen that's actually being delivered in that mixture? What?
FiO2?
Yeah, FiO2, your fraction of inspired oxygen. So the higher airway, or the higher oxygen device, the greater the FiO2, right? So nasal cannula, you've got your 2 to 6 liters, whereas 2 liters would give you about a 24% oxygen mixture. You start applying a 15-liter normal breather mask, or you're ventilating with 15 liters, that's going to give you 100% FiO2. In theory, it's probably going to give you a little bit less, but for this purpose, it's going to be 100%. All right? Diffusion. Did somebody say something? Diffusion. We talked about gas exchange. We talked about inspiration, diffusion. So diffusion is the process of what? That's right. When we talk about diffusion, we're talking about gas mixtures. going from an area of higher concentration to an area of lower concentration. What is the importance of diffusion and respiration? Yeah, I mean, and a lot of times when I'm asking this stuff, I'm not asking for some deep anatomical, getting into all the chemistry and all that. Just simply the importance of diffusion and respiration is the exchange of O2 and CO2. What happens to the oxygen as it's diffused into the bloodstream? Yeah, it's picked up and transported. Ventilation perfusion mismatch. So this is where your airway compromise is going to come from. This is where you're going to need to identify what is causing these symptoms of hypoxia. What is causing these symptoms of airway compromise? Respiratory distress, respiratory failure, respiratory arrest. What is the reason that we are not getting the adequate gas exchange that we need? What is the reason we're not getting the adequate ventilation that we need? Ventilation perfusion mismatch, also seen sometimes as VQ mismatch. On the ventilation aspect of it, those things that I mentioned earlier, how do we get to determine if it's a ventilation issue? Well, look, number one, do they have an airway obstruction? If they do have an airway obstruction, if they were able to move air in, would there be any issue with gas exchange? Probably not, if they're choking on a hot dog or something. Number two, what about neuro? Do they have a neuro issue? Have they suffered a brain injury, or are they having increasing intracranial pressure? Are we having issues in the respiratory control? We may be having those signs of head injury with our breathing, those irregular respirations. Or is it a corrupted chest wall? Are we having problems with actually being able to create that negative pressure? Are we having problems being able to actually get a full breath in? Do we have a circumferential burn around the chest that's inhibiting or impeding the stretch? Do we have a pneumo, a simple pneumothorax? Remember, simple pneumothorax can occur in folks, especially young males, who may be playing basketball and exercising, and suddenly they start having shortness of breath. That could be a simple pneumothorax. What are some other examples of ventilation issues? Issues that could be from ventilation. All right, broken ribs. And it may not necessarily, well, broken ribs, you know, if you've got just a single broken rib, it may not be necessarily that they can't get the full breath, but it hurts too bad for them to breathe. Or if they've got a flail segment, so we're having issues with that. What about overdose? What about narcotics? That would affect the central nervous system. Remember the intact neurosystem? What about perfusion issues? What would be some examples of perfusion issues? And so the way I like to think about it is that my ventilation issues is going to be the things kind of on the outside, kind of like I think about internal and external respiration, but the ventilation issues are going to be the things on the outside. What's impeding my ability to bring oxygen in? And then with your perfusion issues, what's impeding my body from being able to use the oxygen? So with the perfusion issues, we probably are able to get a breath in. We're able to do mechanical processes of breathing, but we're not able to do gas exchange. And there's several things that could impede that. What are some examples? All right, shock. And really, it doesn't matter what type of shock it is, because the basic definition of all shock is inadequate cellular perfusion. But if you look at the actual physiology or pathophysiology of the different shocks, hypovolemic shock. I don't have enough circulation to perform gas exchange. We mentioned obstructive shock with like a tension pneumothorax. So now I'm impeding blood flow. What are some of the other disease processes? What are some that may impede the perfusion? All right. You said sepsis? Yes, sepsis, certainly. What? All right, so cyanide poisoning, where we actually impede the ability to have gas exchange on the cellular level. Before we move on with cyanide, what happens when you have cyanide poisoning? What is actually the medical term? It's cellular asphyxia. Cellular asphyxia, remember? Because cyanide actually blocks the ability of oxygen to be transported. What was carbon? Somebody say carbon monoxide?
They said anemia.
Anemia? Yeah, anemia certainly fall in, and anemia, if not related to like hemorrhagic stroke, if you've just got a patient that is anemic, they've got a low hematocrit, a low hemoglobin, they may still have fluid flow, but they don't have the red blood cells for transport, right? Sickle cell anemia, certainly. Did somebody say carbon monoxide?
Yeah.
Carbon monoxide. And how does that impede gas exchange? Absolutely. So oxygen comes in, but carbon monoxide comes in, and that hemoglobin molecule loves it some carbon monoxide a lot more than it loves it some oxygen, right? All right. Couple of the other big ones are going to be things like pulmonary edema, especially related to CHF, right? Pulmonary edema, where your fluid starts getting pushed back with left-sided heart failure, your fluid starts getting pushed back, and it actually will replace or take the place of the surfactant around the alveoli. And we know that we need surfactant around the alveoli to do what? To increase the surface area of the alveoli, right? And so if you don't have that alveoli, what happens? That fluid sits there in it, and then it continues to get pushed through. You don't have the opening of the alveoli, but then you still got a blockage of the gas exchange, and then we start seeing what signs and symptoms? Pulmonary edema, which would be evident by what? Rails wet like wells. We're listening to that, to those, especially initially in the lower lobes. And we're going to get back to breath sounds in a little bit because I want to make sure I differentiate between a couple of them. But what's the textbook sign or symptom of congestive heart failure as related to pulmonary edema? Yeah, that pink frothy sputum. That pink frothy sputum. All right. So I think we've kind of we've kind of talked about that pretty good. CO2 transport, and again, it's going to be important to understand the CO2 transport in relation to end-tidal CO2 monitoring. What are some causes of decreased CO2 as related to respiratory issues? Hyperventilation in relation to end-tidal CO2 monitoring and all that. Certainly. Why? Why does hyperventilation cause decreased CO2?
You're breathing too fast, so you're breathing everything off.
Right, you're blowing it off. So on the flip side of that, hypoventilation is going to cause increased CO2. Now, let's say that you're bagging somebody and you got them hooked up to end-tidal CO2, and you see a decent waveform. And by decent waveform, indicating we don't see like a shark fin appearance or any of the other abnormal things. There's no issues with the movement. But let's say that they're not in cardiac arrest. We're supplementing their ventilations, but they're in respiratory arrest. Their heart's pumping and all that. So we see a CO2 of 50. What will we do with our respirations, our ventilations? Okay. So if we have a CO2 of 50, that's going to show me that I've got a high. So I'm going to speed them up a little bit, right? On the flip side, if it's 15, 20, 25, maybe even 30. And of course, we also want to assess the overall condition of the patient. We may need to speed up ventilations, right? or slow them down. Yeah, slow them down if it's low. Yeah, sorry. All right. Other terms, and I'm not going to spend a lot of time with these, but a couple of the big ones is this dead space volume. Remember, that's the amount of air that is lost just in that space between the mouth and where gas exchange occurs, and it's typically about what? About 150. 150. And then, of course, tidal volume. Tidal volume, we deliver tidal volume every time we ventilate, right? What are we looking for as far as with good ventilations, good artificial ventilations? Right, and again, this is one of those, there's no black or white, there's no set, you need to deliver 500 milliliters to every patient. Typically what the recommendation is to start with about a half a squeeze of the bag to see where your chest rise and fall is. And if you don't have a good chest rise and fall, then we'll deliver a little bit more. If we feel like we're reaching a non-compliance or we're having trouble squeezing, then we may give a little bit less. But it's going to be patient to patient, all right? These terms, they're pretty self-explanatory. A lot of them, as far as in the acute setting, acute airway management, really don't have a lot of bearing over how we're going to adjust, but there are several things we need to keep in mind, like the dead airspace, the tidal volume, things like that, all right? Now, some of these other terms, if you're looking more at patients that have chronic illnesses and things like that, if you understand how the chronic illnesses work, you would understand why some of these terms would be affected. All right? With airway assessment, when you're doing airway assessment, and of course, airway assessment is critical in every single patient, we always do our ABC unless it is a confirmed cardiac, right? Like cardiac arrest, and that's where we do CAB. You should be able to determine, is this airway adequate or inadequate? You should also be able to determine, is this a stable or unstable airway? Now, what I mean by that is, and I've mentioned it several times in classes before, is we always need to be thinking a little bit ahead. We always need to be looking towards the future. What will be an example of an unstable airway? All right, anaphylaxis. Right now, Zach may be allergic to peanuts, and Will slipped in some French fries cooked in peanut oil or something, and he's trying to kill him. And right now, he may be knowing that he's having some difficulty breathing. When I assess him, I may hear some stridor, and I may hear some bronchoconstriction. But I know that if he's starting to have an anaphylactic reaction, that airway is not stable, and it is going to eventually be compromised. Now, a couple of things I'm going to do to blunt the effects certainly is going to be giving my epinephrine, giving my Benadryl, and maybe a steroid or something like that. But I need to be prepared, all right? What about patients that have inhalation burns? Steam burns, things like that. We need to be ready. We need to be ready. If that patient is giving you ominous signs, and when it comes to things like upper airway injury, burns, anaphylaxis, things like that, and we start hearing stridor, and that stridor is getting worse, that's an unstable airway. It's only a matter of time. What would be some potentially difficult airways?
Trauma patient with trismus.
All right, trauma patient, head injury, trismus, or trauma patient, facial injury. Lefort fractures, your facial fractures, maxilla fractures. Patients with maxilla fractures, those may be unstable. And you need to be able to determine, you know, a lot of times we like to go with basic airway stuff. But as a paramedic, you've got to use your critical thinking skills and your evaluation skills to say, hey, you know, this is going to be one of those rare occurrences where I like to go ahead and get that advanced airway in because I know that this airway is going to shut off and I'm not going to have access, and the next steps is going to be needle cric or surgical cric or something like that, right? And again, that's going to be a very last-ditch, last-resort effort, all right? Knowing your steps for proper airway assessment, knowing what are the key findings, and then also a good airway history, You know, going back to his example, and it seems very basic, very elementary, but if I'm assessing this guy and I'm starting to see signs and symptoms of anaphylaxis, Will's over here trying to kill him. Will ain't going to tell him that, hey, I just slipped you some peanuts, right? So we need to be digging. Are you allergic to anything? Have you eaten anything recently that was different? Do you have any type of past history? Also, again, the importance of home meds and understanding your home meds. You know, you come to this patient, difficulty breathing, and you look around and you see an Advair discus, or you see I don't know, diuretics and some of the other things, theophylline or pills, you know, things like that. That's going to help you out. It's just lightning, it ain't going to hurt you. All right. So with your assessing, check proper ventilation. And guys, I know that this is just your basic airway stuff here, but again, your basics is what's going to save you on exams and in the field. All right? Looking for that VQ mismatch, all of which could be found through signs and symptoms, right? Air movement. If I don't have air movement, there might be a ventilation issue here, right? If I don't have a adequate skin color, if I'm not my normal skin color, I'm pale, I'm ashen, I'm cyanotic, we could have a perfusion issue here. Oh, I know a couple of Biots myself, but I don't know about y'all. Biots respirations are some of those abnormal breathing patterns that have the real fast breathing and the periods of apnea and real fast breathing as signs with your head injuries. Of course, we know the normal breathing, and remember, if you think back a couple of weeks ago, I don't remember exactly when we did it, we talked about those tracheal sounds and the bronchovesicular sounds and things like that. I'm really, at this point, I'm more concerned with you being able to determine the abnormal ones, because you know what normal breathing should sound like. Kussmaul's. Kussmaul's is going to be a good indication of a metabolic acidosis related to what? DKA. All right, your chain stokes, your Biots, your central neurologic hyperventilation, all of them are going to be associated with head injury. Your central neurogenic hyperventilation, those could look similar to your Kussmaul's breathing. But again, if you got a patient that's been ejected from a vehicle, most likely you know that ejection from the vehicle didn't cause them to go into DKA. Right? All right. Your normal breath sounds, also your normal upper airway sounds, which are going to be your tracheal sounds and things like that, but then your abnormal upper airway sounds, which is going to include, we've already talked about a couple of them, snoring, stridor, gurgling. You start hearing gurgling, before you do anything else, you do what? Yeah, turn them to the side, but if that's not an option, suction. Alright? Pulse ox. So pulse ox and we've already talked about a few things that could affect your pulse ox. If you've got the ability to do end-tidal CO2 monitoring, it's going to be much better than pulse ox as far as using it as a guide for airway management. Pulse ox is still a good tool to have, but one of the issues with pulse ox, granted that the patient is not acidotic or alkalotic, they're not anemic, they're not exposed to carbon monoxide, things like that. One of the other main downfalls about pulse ox is that sometimes it takes a minute or two for it to start picking up, whereas with your end-tidal CO2, that gives you a real-time reading. There's many things that can affect pulse ox, whereas with your end-tidal CO2, it's not going to give you a false positive typically. It's going to measure the amount of CO2 that's being breathed out. With your pulse ox, all it is measuring is the saturation of hemoglobin. And it can't differentiate, is this a CO molecule or is this an O2 molecule? It also can't differentiate between anemia or a normal patient. You've got the example that I used. If you say that normally you have 5 hemoglobin molecules, and all 5 of those hemoglobin molecules, every one of their receptors are full of oxygen, then your pulse ox is going to read 100% saturated. But then that anemic patient that only has 2 hemoglobin molecules, if those 2 hemoglobin molecules are fully saturated with oxygen, it's still going to read 100% saturated. Does that make sense? So we're going to get a little bit here into capnography in a few minutes, but I told you a lot of these things that already. Pulse ox measures oxygenation, capnography measures ventilation, but it can also give you a very good key into metabolism, right? And if you have good CO2 coming out, then you've got to kind of assume that you had oxygen going in to create that CO2 through the metabolic processes. Here's one of the biggest problems. Reflex changes in oxygenation. It may take 2, 3, 4 minutes, whereas less than 10 seconds you have the real-time changes with ventilation. And again, they're both directly related to each other. And it's a delayed detection of hypoventilation and apnea, whereas CO2 is an immediate detection. They both should be used in conjunction with each other. All right? So with your pulse ox readings, 95 to 100, we're okay, right? We're okay. Our goal is 95%. 91 to 94, that's mild hypoxemia. Increase FiO2 to increase oxygen saturation. What will we probably use to increase FiO2 with a 91 to 94%? Yeah, 2-3 liters nasal cannula. You don't need the 100% oxygen, all right? You don't need that. And I would say 9 times out of 10, your patients, if they are having some type of issue, are going to be in that 91 to 100% range, right? Think of, for those of you that work on the ambulance and have done clinicals, think of the times that you've seen a patient that has less than a 90% or 91% O2. Very rare do you see that, right? But again, one size doesn't fit all, right? One size doesn't fit all, and just like with any other disease process, sometimes the body kind of gets used to these not normal ranges. The body likes its numbers, but sometimes the body kind of gives up on its normal numbers and says, hey, if this is all we're going to get, we're going to work with this. So I may have that patient that has a history of a chronic lung disease, COPD, emphysema, chronic bronchitis, something like that, and they may naturally live 90, 91%. Good history. If they're on home O2 or they're 500 miles of oxygen tubing going all through the house and all that, then yeah, let's just hook them up and keep them maintained, you know. But with those kind of patients, our goal is not to rapidly increase that SpO2. You know, on paper and in theory, the whole hypoxic drive comes into play with that, right? But typically in the acute setting, we're not going to really knock out their breathing drive if we do increase their O2, but their body is used to that, all right? Remember, they breathe off of different pathways that we'll talk about in a little bit, all right? Pulse CO oximeters, just different real-time monitorings that you, I don't want to act like I know it all, which I don't. I don't foresee anybody working in a lot of these immediate areas ever really having anything much more than maybe a portable CO2 detector or a portable end-tidal CO2 monitoring. But these will monitor your carboxyhemoglobin, your methemoglobin, and also total hemoglobin. In the acute setting, in the here and now, we're trying to manage this patient's airway. A lot of these really are not going to be of as much of an importance as your SpO2 is. Right? All right. Know your terms with your carbon dioxide monitoring. Remember that there is a difference in capnometry and capnograph. All right? Now, they're both going to be hand in hand. We're both going to be reading them, and they're both going to give us the same values, but they're going to be a different view. Your capnometry is going to just be what?
Number.
Yeah, it's just going to be that little number in the corner there. We want that to be what? 35 to 45. Where your capnograph, just like an electrocardiograph, is going to be a waveform. All right? Same with your capnogram. End-tidal CO2 is what those are measuring. The fraction of CO2 that is breathed out. Your PET-CO2, your PETCO2, is going to be your partial pressure of end-tidal CO2. Your PaCO2, that's going to be your partial pressure of arterial CO2. And then the end-tidal gradient, which is going to be the average of the CO2. All right? Couple of terms here, or a couple of rules here that I think that you should have that basic graph just based off of what we've asked, but a lot of these are going to reflect, all right, we've got this patient hooked up to CO2. We've got this patient, we're managing this patient, but now we're starting to see changes. We got a sudden drop of end-tidal CO2 to 0. We've had this patient intubated. We've been bagging and things have been looking good, but then suddenly we go from 35 and we see that waveform just kind of crash, plateau off, and it's 0. What's going to be one of your first thoughts?
Check to make sure your tube is still in place.
Yeah, because it most likely 99.99% of the time, if you have an end-tidal CO2 that just drops to 0, it's going to be an equipment failure, because even if it's some other metabolic process going on in the body, you'll still see some other waveform, some other number. If you've got that patient intubated, is it unheard of that you could have an esophageal intubation even though initially you had confirmed that you had put it in the trachea?
Yes.
It's not unheard of, it is possible. Right? Think about, you've got the patient, you got them intubated. You lift them up, you move them to the stretcher. You have to go down the elevator a while back and you load them up on the ambulance. That's a lot of movement for that latex pliable tube, right? That's why constant end-tidal CO2 is very important. Just a sudden decrease, but not a drop to 0. So if you have a drop to 0, Either you've got a complete disconnection or you've got an esophageal intubation. Sudden decrease. There may be a leak. There may be a compromise in the sampling tube. There may be something like that going on. It may be a partial disconnect, or it may be a partial airway obstruction. What would be an example of a partial airway obstruction if you have a patient intubated? Do what? Okay, all right. Yeah, going back to some of the diseases we talked about earlier. What about that patient that's got pulmonary edema, whether it's from CHF or it's from a non-cardiogenic? It may be fluid in the tube and you need to suction, all right? What about if you have an exponential decrease of end-tidal CO2, but you still have a waveform? A decent-looking waveform. And if you understand how all this works, then you can really start putting it together that you don't have to memorize this, but you can understand, I need these numbers to be this. If I have a complete drop and loss of waveform, then something's become disconnected. If I've got a sudden decrease and probably an issue with the waveform, then something like this has happened. But if I have a normal waveform, but I was going 35, then suddenly I'm down to 25, now I'm down to 20, now I'm down to 15, but I still have a waveform going here. That's probably going to reflect some type of metabolic issue, right? Pulmonary embolism. Could that occur while you're caring for your patient? It could. Cardiac arrest. Could that occur while you're caring for your patient? Yeah, especially if they're in respiratory arrest. Sudden hypotension. Hey, let's say that they had an infection and they were showing signs of sepsis, and then while we were taking care of that patient, that sepsis has decided to really overtake the body. That is not unheard of. Or severe hyperventilation. That could occur even if you're bagging at a normal rate, because that patient could start getting some neurofunction back and start breathing on their own some. Change in CO2 baseline, mechanical error, water droplet in the analyzer or the tube. All right, what about on the other side? Sudden increase in end-tidal CO2. What about, and it doesn't mention this, well it does, sudden increase in blood pressure, but what if you're working in cardiac arrest and you're bagging this patient and they were in V-fib and you've given your epi and you've given your amiodarone and you shock and suddenly you start seeing it go from 15 to 18 to 20 to 25 to 30. That's a good sign, right? That's a good sign. Now, let's say that you've got a patient that has a trauma or something like that. You got a tourniquet on. That tourniquet's been on for a little while. We're breathing for them, 35 to 45. Our CO2 is showing that. And then suddenly it starts spiking up. 35, 40, 45, 50, 55, 60. I'd be checking that tourniquet. Because what's below that tourniquet? Yeah, your toxins. Remember, whenever we put a tourniquet on, we're impeding flow. If we got that thing tight enough to impede arterial flow, we certainly have it tight enough to impede venous flow, right? So that may be those toxins coming back. Gradual lowering of end-tidal CO2. And again, what we see here as opposed to here, these are going to be sudden drops and sudden, all those are sudden. But gradual lowering, hypovolemia, decrease in cardiac output, cardiogenic shock, and gradual increases in CO2, hypoventilation, CO2 absorption, things like that, all right? With your capnography, you've got your mainstream and your side stream. Your mainstream is what we use with our UT tubes. They're more accurate, all right? Your side stream, sampling tube and analyze an analyzer sensor away from the patient. All right. We got 9:30. Let's take 5 minutes. Respiratory system assessment with capnography reflects exhaled CO2 concentrations over time in 4 phases, as reflected on that wave. Some of the things that it can give us a good indication of with waveform as well as obstructive disease, rebreathing. Remember that Curare cleft where a patient is paralyzed or sedated and then that starts wearing off and they start trying to take a breath on their own. Also esophageal intubation or endotracheal tube or circuit leak. With our medical conditions that we're also looking in our respiratory system assessment, we've already talked about that. Directly related with airway, your VQ mismatch. We talked about examples of that. Apnea and how you would work with that. You would breathe for them. Hyperventilation, hypoventilation, and then your pulmonary disease, and then in parentheses there, it says shark fin. Your pulmonary diseases, your reactive airway diseases, or other diseases that cause bronchoconstriction. Makes sense why it would give you a skewed waveform, because you've got a slower exhalation process. You've got air coming out slower because of those constricted bronchioles. All right. With the evolution of the waveform, when they are breathing in, when a patient is breathing in, the lungs are free of CO2 gas. So our end-tidal CO2 is only measuring CO2, so if there's no CO2 there to measure, what are we going to see? Flat. We're going to see baseline. As carbon dioxide starts diffusing into the alveoli and equilibrates with the end-alveolar capillary blood, it starts filling the lungs, and this is the process or the point to where we're about to get ready to start exhalation. We've had gas exchange. All right. Right now we're looking at the anatomical dead space as they're breathing out. Then with the higher ventilation, alveoli with higher ventilation in relation to perfusion, they have lower CO2 compared to the alveoli with a low VQ ratio that would have higher CO2. As it moves, the concentration of CO2 decreases gradually to 0. Volume of CO2 free gas is termed your respiratory dead space. All right. Now, this is where we're going to start seeing the CO2 concentration rise. CO2 was in the body, now it's coming out. So as we're breathing out, it's picking up the amount of expired CO2. The gas that's being breathed out as compared to the gas that's being breathed in is CO2 rich. At the end of exhalation, where that patient is not breathing out anymore, you're going to have a peak of CO2 to where it's not going to be red anymore, right? There's no more CO2 to come out. That's where you're going to start seeing your plateau. Then it's going to rapidly decrease. The amount of CO2 is going to rapidly decrease because now we're breathing back in, starting to breathe back in oxygen-rich, CO2-absent gas. All right? This is one of those things with healthy lungs that all humans are going to pretty much look the same. And anatomically and physiologically, the respiratory tract, the amount of CO2 that's coming out for healthy breathing should be the same. All right? And then you get back down to you're trudging back down to your baseline. All right? So on your capnogram here, A represents the baseline. This is the beginning of expiration, and again, like I just mentioned, it is CO2 free. Then you've got the B, that's your transitional part. That's where you start having your rapid increase in CO2, mixing the dead space with alveolar gas. So that's the first point of expiration. Talks about the alpha angle and the beta angle. Not too concerned about those at this point, but they should look very similar on all patients. represents a change in alveolar gas. At this point here, what we are breathing out is CO2 rich gas. So this is what we're measuring here is a CO2 rich gas. The alveolar part of the curve represents the plateau average. This is the average amount of CO2 that's being breathed out with each breath. Entitled carbon dioxide value, E. So this is your top point. So this is where you would measure in relation to your graph. Does that make sense? So in waveform, this is still showing me that I've got probably a 38 millimeter of mercury CO2. With capnometry, it should reflect that as well. I should see a digital number there. All right. The beta angle, which is F. This is the change, and then G is where you have the inspiration. So this is where we're free of CO2 gas, and we're starting to breathe back in, and of course the capnogram is not going to read that. With your changes in waveform, so this is what we were talking about, the shark fin. So if you go back to here just a minute, if you notice that it should be kind of a pretty vertical, rapid release of CO2, right? So it goes pretty quick. With your shark fin, this is going to be a direct indication of bronchoconstriction. So you've got these patients that retain gas, so they breathe in, and it's almost like that one-way trap with an animal. The animal can get into the trap, but then the lumen of the trap is so small once they get in that they can't get out. Does that make sense? It's like that with these bronchoconstricted bronchioles. They can get the air in a lot of cases, but then they retain or they have gas trapping. So it's a slower evolution of CO2 coming out. It's a slower amount of volume, slower amount of air coming out. That's why you get the shark fin. If you notice, there is a very definitive difference. Whereas this pretty much goes vertical, the shark fin, it has a definite angle to it. Also, what's important to remember about that is that they do not have that plateau or that CO2 baseline where they can get all that CO2 out. Once they finally get that exhalation or that breath out, now they're getting ready to breathe back in. So naturally, what's going to happen to the CO2 that a normal, healthy person would breathe out? It's going to be trapped. So these are the patients that if they have a chronic illness, you may call a CO2 retainer. These are the patients that end up with CO2 retention. They have that pink skin, and they also suffer from polycythemia. Remember that term? Polycythemia. All right. Your Curare cleft. Your Curare cleft. This is what I just mentioned earlier. You would only see these in patients that have been paralyzed, partially. They've been paralyzed, but then as that paralyzation starts wearing off, they may start making their own respiratory efforts. Part of the normal human nature process. If you do not have something that is restricting your respiratory effort, you are naturally going to try to breathe. So what this is representing is a ventilation, and then this right here, when that CO2 declines, is going to represent what? Not exhale, inhale. The patient's trying to inhale. They're trying to take take their own respiratory effort into consideration here. But then, because they are still partially paralyzed, they're not going to get a good full breath, and then we're going to take back over. If you're working in a system that allows for you to do RSI, that you paralyze a patient, and you see this, what you going to do? Yeah, you're either going to be prepared to extubate and allow them to wake up, which is probably not a good idea at all, or you need to increase sedation. If you notice on this waveform, it's got this guy right here, so this is where he tried to take a partial breath. You do not need to let this go on for a long time, because if those paralytics are starting to show signs that they are wearing off, they're only going to continue to wear off. All right. Sometimes with patients with emphysema, they may have a reverse slope. Remember, on the normal waveform, your high peak should be on the right side. And it has to do with the respiratory, their illness, and they're getting that CO2 out, but their max amount of CO2 they get out is on this side. Won't see that as much. Right main stem bronchus intubation. Initially, the peak is due to the carbon dioxide from the well-ventilated lung. Now, and I remember talking about this, if a patient is unilaterally intubated, you're still going to have residual gas that goes over into the left side, and it's still going to have a partial exchange, but you're going to see that evidence with two different waveforms. See, this one never reached full baseline, so what you're actually seeing is a right main and then a left main. Or you could see it where they're overlapping on each other. But you should also be listening, and you should be reassessing your tube. One of the key things when you first put a tube down is going to be noticing what? Bilateral chest rise and fall, equal breath sounds, and tube measurement, right?
Would this kind of fall under the rebreathing kind of category where it's not proper ventilation?
They may. It may, because, like I said, that left side is still going to get ventilated, so it may take in some of that stuff.
Okay.
Most likely not, though, because that right main stem is intubated, and so it's going to be a direct access for that volume to go out. All right. Esophageal intubation, sometimes you may have a little bit of CO2, but it's certainly not going to give you a waveform, and it's not going to give you a good capnometry reading. So if you see something baseline, you need to be looking for those other things like sounds over the epigastrum. You start seeing this, don't allow that patient to have time to start to start getting lots of air trapped in the stomach and have that gastric distension. Okay. You may also sometimes see these where you've got a leak. If it's a full full corruption in the circuit or the system, it's going to be baseline. This may indicate a leak between the sampling tube and the capnogram, and you've just got two different waveforms here. Again, you want to see that normal plateau, that normal baseline, and if you start seeing any deviation of that, then you need to start going through your mental checklist of what are the issues, okay? Sometimes with pediatrics, they may have variations that are normal. They may have normal variations, and we'll talk about that more this summer. We're not going to focus a lot on pediatrics right now, but they do have smaller tidal volumes, and sometimes their inspiratory and expiratory volumes and times are a little bit different. Okay? All right, so we've seen these before. What would this one on your left indicate? An increase in CO2. Yep. On the flip side, and it's continuing right now, it's just a static strip, but it's going down 28, 27, 26, and you see those waveforms getting smaller, and you also see them getting more narrow. Hyperventilation. And also you see that they're not quite getting back to that baseline, so we're not having that full cycle. Other stuff, carbonated beverages in the stomach. If they just drank a Coke and then you intubated them, you may see some really weird stuff there, okay? We've talked about seals, decrease in CO2, we've talked about that. Okay, what would a rise in CO2 level during CPR mean? ROS. All right, return to spontaneous circulation. According to the American Heart Association algorithmic guidelines, you want end-tidal CO2 during resuscitation to be above what? It's lower than you think. 10. on your algorithm, on your 2015 algorithm for PEA, asystole, your cardiac arrest algorithm, if you've got end-tidal CO2, you want it greater than 10. And it only makes sense that you really can't expect somebody that's in cardiac arrest with us artificially pumping their chest, artificially ventilating them, to have a normal value. All right? Advanced airway management. We're going to talk a little bit about your different tools just to refresh on that. Of course, your ET, your endotracheal intubation, that's going to be your definitive airway. That's going to be your preferred for an ALS provider. That's going to be your definitive airway for securing it. Why would you intubate? Obviously, respiratory or cardiac arrest, somebody that is unresponsive, but not just unresponsive, but unable to maintain their airway. Sometimes you do have unresponsive patients that are able to maintain their airway, but those are also the things that you've got to be considering as unstable airways as well. Risk of aspiration. How about someone that's had a big stroke or something like that? Obstruction due to foreign bodies, trauma, burns, anaphylaxis. Respiratory extremis, severe respiratory distress. Also, symptomatic pneumo, hemo, or hemopneumothorax with respiratory difficulty. What are your advantages? The number one advantage is going to be you've got direct access to the airway. Number two, if it's in the right place, it's going to prevent gastric distension and prevent aspiration. Eliminates the need for a mask seal, and also gives you a very good direct route for suctioning and for end-tidal CO2 monitoring. You can also use it for medications, and we talked about that the other day. Remember, you double your dose of medications when you give it down the tube. What are your disadvantages? Well, as y'all have seen, working in the lab and then going over to Jack Houston, there is a difference, a huge difference between a plastic mannequin and a real person. And I would believe that most of y'all can vouch for this, that there would even be a difference in a person in a controlled setting on an OR table and a person that's in their bathroom having cardiac arrest, experiencing cardiac arrest, or a person that's been in a car accident with a head injury. There is a big difference, and it requires experience, and it requires training. And the first times that you're out in the field and you're doing it yourself, you're going to realize, hey, this is taking a lot of time. It can take resources. You've got to make sure that you've got the available resources for you to take the time to do it. Also, your equipment, and you've got to know what you're comfortable with. And you also need to be able to assess that patient to determine what size tube they're going to need, what type of blade are you going to use. Requires direct visualization of the vocal cords, which can be easy if it's a cut and dry cardiac arrest, normal sized person, but then you've got big people. You've got people that their anatomy is different, very anterior airways, posterior airways. You've got trauma, blood, fluids, things like that. It also bypasses the upper airway functions of warming, filtering, and humidifying the inhaled air. That's not going to be a big deal in the acute setting. A patient cannot stay intubated without being on some type of artificial humidification and artificial warming. All right? Also, equipment malfunction, not just with the circuit, but with the tube itself. We've already talked about an example or two. The tube, even though you think you've got it super secured, may come out. Teeth breakage and soft tissue laceration, which will further increase bleeding and inability to visualize. Hypoxia, especially if you're trying to intubate, it's a difficult intubation. You get tunnel vision, and the next thing you know, you spent 2 minutes trying to get this airway, and that patient hasn't been ventilated. Esophageal intubation, you might as well write them off as dead if you intubate that esophagus and continue to bag it. Endobronchial intubation, right main stem bronchus. We talked about that just a minute ago. Also, tension pneumothorax. You've got to consider that, especially with these patients with chronic lung diseases, COPD, emphysema. What occurs on the lung wall with these patients that have chronic illnesses, weaker lungs? What occurs on those lung walls? Starts with a B. Almost like a aneurysm on a vessel. A bleb. So a weak spot in the lungs. And so as we're ventilating, we're pushing positive pressure down, which is an unnatural process of breathing. And as we're forcing that positive pressure, if you've got a person that's got weak lungs and blood's on the side, you could cause pneumothorax. You could cause that barotrauma. All right? Remember with your Macintosh and your Miller, your Macintosh is designed to go in this little spot here called the what? Vallecula, whereas the Miller blade is designed to displace the what? The epiglottis. You've got to be careful with those. In pediatrics, the preferred blade is what? The Miller, because of the anatomy of the epiglottis. All right? When I put the tube in and I fill this up, how much goes in there? 10. 5 to 10 milliliters of air, enough to secure. What happens if I put too much air in that tube while it's in the trachea? That's right, it could cause ischemia of the tracheal tissues. Alright? This is just an example of that ring tube. Did I ever get that thing out and show y'all? I don't think I did. We've got some down there. It's pretty neat. You grab this little ring right here and you can actually make it kind of bend to follow the anatomy. Alright? Make sure that balloon is able to take air. There's other ways. This one's that lighted stylet where you put the stylet down and then you follow the light. Transit illumination, probably not going to be a very easy thing to do on the back of the truck. All right, blind oral tracheal intubation by the digital method. When would you digitally intubate somebody?
They do not have a gag reflex.
When would the book say that you would digitally intubate somebody? Do what?
They do not have a gag reflex.
All right, no gag reflex, and you're in a position where they need an immediate airway, but you don't have direct access to laryngeal visualization. Insert your middle and index fingers into the patient's mouth. Try to get it open, and use your fingers to help guide it. You want to make sure they ain't awake before you start putting your whole hand down in their mouth. All right. The other thing, nasal intubation. Nasal intubation. I forgot to include it on here, but your nasal intubation. When does the book say nasal intubation is recommended? All right. The patient should have the ability to breathe on their own, and they need to be managed. If you've got issues in the face, you've got inability to secure a tube through the oral route, so on and so forth. All right. RSI. So this is when the patient, they may not necessarily be awake, and they may be awake, but they may not necessarily be awake. But one of the key things here is either they're clenched down or they have an intact gag reflex. All right. So with our rapid sequence intubation, very, very critical to remember that you cannot give paralytics without giving sedation. Right? Because what do paralytics do? What do paralytics, how do they affect the body? Right, so they are neuromuscular. They do not have any effect on the central nervous system in relation to alertness and things like that. They're neuromuscular. You've got your depolarizing and your non-depolarizing agents. With your depolarizing agent, which the most common is what? Succinylcholine. What do you expect to happen after you administer it? All right, fasciculations, the shaking or the twitching. All right. For your induction agents, Versed, Valium, both are going to be in the benzo. Etomidate, ketamine. Ketamine is making a appearance in protocols. Ketamine is coming. Ketamine is a dissociative anesthetic.
We just got that on our truck today morning.
Oh, really?
Yeah.
I think that they're about to approve it for Alabama protocols as well. Propofol, fentanyl. And then, why might you give atropine as a pre-medication? Yeah, you got that, what? You got that rebound bradycardia. One of the things that could be detrimental to intubating a patient is stimulating that gag reflex. I mean, the vagal nerve, not gag reflex, but stimulating that vagal nerve, which it innervates through the trachea, so you could actually cause them to brady down even when you're trying to intubate. All right? Really quickly with pediatrics, that pediatric airway, know that they're not just little adults anatomically. They've got disproportional sizes in their head. They got that big watermelon head. They're smaller, more flexible than an adult. Their tongue, in relation to the rest of their mouth and their head, is proportionally larger. They got that floppy around epiglottis, while it's a preferred blade is the Miller. The glottic opening is higher and more anterior. The vocal cords slant upward and are closer to the base of the tongue, and the narrowest part is the cricoid cartilage. Now, what are some of the issues with ventilation? Well, number one, you need to make sure that you've got the right size. Whether it's an infant or a pediatric, you need to make sure you've got the right size mask. Also, that bag size depends on the size of the child too, because smaller children, especially babies, infants, they cannot take the tidal volume that a larger bag would take. You would cause barotrauma with them. Then, of course, ventilate according to current standards. And you know how to assess the adequacy of ventilations. Remember this little formula here to determine ET2 size. Age in years plus 16 divided by 4. So if I've got a 4-year-old child, 4 plus 16 is 20 divided by 4. They would say that that child needs a size 5. Now, one of the things that we know about a pediatric ET2, the smaller sizes, is that they do not have what? The cuff. Why? So, you could in turn actually do more damage by inflating a cuff on a child, even to the 10 millimeters, than if you just put one in and that cricoid ring is supposedly supposed to be able to hold it in. Also with the child, remember, their airway goes like that. So it's bigger in the top and it starts doing that cone shape, which explains why children are more prone to foreign body obstructions and all, because again, it's like that trap. The stuff is able to fall in easier, but you can't get it out because it's in the smaller lumen. Yes, sir.
At what age does that formula stop working?
I would say I really don't know. I would probably say once you get past around that 5-year-old range, 4 or 5-year-old range. And again, you've also, with children, well, if you look here, if you just go by this right here, and now this is just a Nick thing, I don't think there's anything in the book. But if you look here, school age, even school age, 5.5 to 6.5 uncuffed, you're going to be hard pressed to find a 6 or 6.5 that's uncuffed. You're going to be hard pressed to find a 5 or 5.5 that's uncuffed. So I don't know a black and white. You really got to look at the size of your child. And used to, when I was coming through, they used to say like 8 years old. It was kind of the marker there. But I think that as McDonald's has become more popular and Happy Meals have become more popular, they say, I don't know, that 8-year-old's 180 pounds. That ain't going to work. Y'all laugh. I saw a kid on a rec league baseball team the other night on the other field that, you know, is as big as I am. He was shorter than I am, but he was as big as I am. All right? Is that funny? All right. When goes back to that question about nasotracheal intubation, it may be useful in some situations with children, more so than with adults. But when do you intubate a child? When do you put a advanced airway in a child? When all else has failed. When all else has failed, there's a lot that can go wrong with a pediatric intubation. Even in cardiac arrest, if you can bag, if you can do basic airway adjuncts, don't try to intubate. If you do, you need to call the doctor first, see what they want you to do. All right. And actually, this is not for children. This, I don't know why nasotracheal intubation just showed up, but it did. When is nasotracheal intubation useful? Possible spinal injury, clenched teeth. You know, you can't get it in the mouth. I mean, that's pretty much that. What are the advantages? The head and neck can remain in neutral position. It really is a pretty easy procedure. And sometimes, honestly, it may be a better nasotracheal intubation, maybe a better choice than endotracheal. And why? Well, what if you're working in a system like many of us work in right now that doesn't allow for RSI? But you've got a patient that does have trismus. Now, one of the indications, one of the issues you're going to run into there is, what's the cause of that trismus? Do they have a head injury? Then we really can't put anything in the nose, can we? But if they're in like status epilepticus or something like that, or status asthmaticus or something like that, all right? It could be potentially more traumatic for patients. I mean, if you're sticking something up the nose, especially something that's as big as the ET tube. Now, an NG tube, what do you think would be an indication for an NG tube in the field?
If you esophageal intubate them and got a tracheal intubate, you can substitute or relieve the gastric.
All right. And it doesn't have to be just post-esophageal intubation, but it could be any time that they have severe gastric distension. Because gastric distension, that stomach is a balloon, essentially, and if it starts filling up, it's going to create pressure on the diaphragm, and it's going to impede the ability to expand and contract. All right? But where I was going with that is that the NG tube is tiny compared to a 6.5, 7, 7.5 ET tube. All right. Improper placement is more likely when performing blind nasotracheal intubation as well. I don't have a clue. I don't think this really, this would be more of trying to find bats in the cave. I would imagine not, but I don't know.
I'll never look down on loaded gun. That's for real.
That joker just likes to lick your noses. Ma'am, just hold still, I promise. This is standard procedure. All right. Esophageal tracheal airways. I will say this. I do remember we didn't talk about PTLs very much because we don't use them in this area. But you might want to just read over that little section about PTLs. I don't even remember right now, to be honest with you. It's in your airway. Look under the blind insertion airway devices. Laryngeal, tracheal, lumen, I don't remember. All right. This right here is showing the esophageal tracheal or the combi tube. It was popular when I was getting into all this. Now these have been replaced with the King and the LMA and things like that. But it's one tube, 2 lumens. Luck of the draw, most of the time the big part's going into the esophagus, and then it's going to ventilate off of your lumen here. If by chance the stars align right and the anatomy is right, then it may actually perform a pseudo intubation. It may go over in right above the vocal cords, and then you would ventilate through the other lumen. All right. advantages of the combi tube, and really could be advantages of most of the other blind insertion airway devices, is that they are blind insertion airway devices that are going to give you a more definitive airway than just bagging alone. Insertion's rapid and easy, does not require visualization of the larynx or any other special equipment. You do need to know how your particular blind insertion airway device works because there's several different ones. Of course, there's other disadvantages such as cannot be used in a conscious patient or those with a gag reflex. Let me ask you this. Would you be able to get capnography off of a blind insertion airway device? Yeah, you should be able to, yeah. You do colorimetric, don't you? As a confirmation, you do colorimetric, so it reads CO2. Okay? Placement of combi tubes is not foolproof. Errors can be made, but if you know what you're doing, and if you know what you're listening for, then you can overcome those errors. It says other intubation devices. I would go more along the lines of other blind insertion airway devices. Yeah, the PTL, the pharyngotracheal lumen airway, that's one of the older ones. This esophageal gastric tube, that's a really old one. And the esophageal orbiter airway, the LMA just sits, it is a tried and true supraglottic. It is designed to go over the glottic opening. Alright? Direct visualization of the larynx with a laryngoscope may enable the removal of an obstructing foreign body. I would remember that. You've got patients that are choking. You've tried slapping them and CPR and all that kind of stuff. You did a quick visualization, there's nothing there. You can use that laryngoscope as a next option to try to visualize and get those McGill forceps and pull it out. Alright?
If they're choking on something like that, and you stick that laryngoscope down there, are they not going to gag? Or
I mean, they already gave.
Yeah, I mean, probably will, but you know, it's one of those things that if you don't get that out, your next and only other option is going to be cry. You know. All right. All right. Quickly, surgical airways. When do you do a surgical airway? Last resort. Last resort. Inability to establish an airway by any other method. What are we looking for? What are we palpating for? What are we trying to find? The cricothyroid membrane. Right here. Right here. Alright? Whether it's needle cric or it is surgical cric, that's the opening. That's where the opening occurs. Alright? You want to locate and palpate the cricothyroid membrane. On men, it's not going. It should be a little easier to find if you've got a very predominant thyroid cartilage. Adam's apple. You go directly below that. All right. There's a couple of different types of crics. You can also, when we've got a couple of kits down in the lab, you got your percutaneous cric, which the lumen is bigger than a large bore needle for a needle cric, but it doesn't require surgical incision. It's got that sharp catheter that you place in and then you push it over. With this is going to be a large bore IV catheter. Then you have to place, you can put an ET tube, little hookup on the end of it. But you've also, in order for this to work right, now most places do not have the needle jet insufflator. You mash a button and it goes psst, psst, and it forces high flow volume of oxygen in or air in. You can also ventilate with a BVM. Now, again, this is a last-ditch effort because if you think about if somebody is intubated, you're bagging through something that's this big, and this is just in relation, but then if you've got somebody that's got a needle crite, you're bagging through something that's much smaller, and so it's going to be very much more difficult. Very rarely used. Your open crikes, your surgical crike, and this summer, if everything works out right, I'm going to get Lee to come in, and we're going to have one of our labs is going to be this, and we've got some pig trachs, and you're going to do the surgical crikes and all that, and learn how to do all that. All right. But this is where you're going to make an incision, and you're going to open it up, and then you're going to put a tube down. All right. This is a Shiley here. Well, this is just a tube, but you can't have a Shiley. If you've got somebody that's got a trach, and you start having airway issues, one of the first things you need to do is to check that lumen, to check that inner cannula. If they've got a chronic trach, check that inner cannula. You can take that inner cannula out and check it and clean it or replace it. All right. And then bag. All right. Now, what about patients who have a stoma that we didn't create?
Pediatric mask.
All right. The biggest problems with somebody that has a home trach or even just a home stoma is going to be mucus plugs. We would suction. Now, what's important about that is that if we go to suction, you need to get your sterile suction out, you need to get your sterile water out, and you need to get your sterile gloves out. Don't just stick that suction tube that's hooked up to the suction on the back of the truck down there. Because even though it is an artificial opening, you're sticking a tube down in the lungs that you could be introducing foreign pathogens into. This is what I was talking about, the Shiley. So the white part is what is the holder, it stays in there. This part right here is the inner cannula. And I didn't show y'all that this semester, did I? We've been so busy with scenarios and stuff. I need to show y'all that. Well, I thought I might happen to have one, but I don't. But this is the part that would come out and can be cleaned or replaced. I don't know what the typical replacement is at home. We replace them twice a day in the hospital with patients that had trachs. And that's because what we mentioned earlier, all the artificial filtration, all that stuff is gone when you bypass the normal airway function. All right? Suction in, no more than what? How long?
10 seconds.
All right, 10 seconds. Be prepared to suction at any time that you start getting obstruction while managing the airway. All right. Gastric decompression, and we've already talked about that. NG2. You want to decompress the stomach if that thing starts getting bloated up because it's going to impede the ability to breathe good. All right. NG2 and OG2. OG2 is pretty easy. And usually that's going to be in conjunction with somebody that's already been intubated. So if you've already got one tube in one hole, it's only got one other place to go. So usually OG is pretty easy to go in. The NG, they need to be awake and able to swallow if at all possible. So what I'm saying here is that if you're working in cardiac arrest and you start getting lots of gastric distension, then you may want to just consider slipping an OG in really quickly, and then they can put one in. I've placed many NG tubes, and they're not easy on an awake person, so they're even harder on a person that's not awake, because what you do is if they're awake, start placing it, you actually get them to swallow some water. You prepare them for all this water-soluble lube that's about to go in their nose, and this thing's about to go in their nose, and you start putting it in, and you hold them anterior, and then you just say swallow, 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 keep swallowing, keep swallowing, keep swallowing, keep swallowing. Then you get it placed in. Then you you push with a big syringe, you push air down, and then that's the time you want to hear gurgling in the stomach. You may also hear, if you've got gastric distension, you may also hear air escaping as soon as you hit. Also, I caution you, if you decide to put any type of gastric tube down, OG or NG, be prepared to see what they ate for supper broken down with chemicals, because it's going to come back green and it's going to be nasty. If that's the case, if you've got a gastric tube that has a cap on it, either place the cap on it or hook it up to very, 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 very low suction. Very low suction. This is going a little bit farther than what we need to, but just FYI, if you put that thing down and you get that gastric content back up, you don't want to rapidly suck it out, because that's going to affect their pH balance. All right, because where is the most acidic environment in the body? The stomach. So if you suck that acid out, that's going to affect their pH, which in turn is going to affect everything else. Okay? All right, quickly, oxygenation. I'm not going to spend time with your oxygen cylinders. This is older stuff. Y'all should know these by now. All right? How long will it last? Tank pressure and PSI times the C factor. This little thing right here times liters per minute. Not going to see that. Not right now, at least. All right? Your oxygen delivery devices. You should know all of these. Your lower volumes, your nasal cannula, your venturi mask. What is good about a venturi mask? That's right. You can control the FiO2 without giving them 100% FiO2. It goes up to about 55 to 60%, I believe. So I can give them a higher amount of FiO2 without it being 100% oxygen. Simple face mask, partial face mask, and then the one that we all love, the non-rebreather mask. Small volume nebulizers. What constitutes a small volume nebulizer? The ones that we squirt 2.5, 3 milliliters of albuterol in. They either come as the mask or as the puffer. All right. And then oxygen humidifiers. Okay. Y'all should be good on ventilation methods. That's a Devan valve mask, also called a flow restricted oxygen powered ventilation device. They used to use those. Here's the deal with those though. I'm sitting here, I'm bagging Marion. Hey Nick, do you know the directions to get back to the hospital? Yeah, just go turn down over there. And the next thing you know, you done inflated her lungs to the point to where they're about to blow up because you forgot you were oxygenating her there. You don't see these very often. They are still available, and they may use them in the hospital, maybe in the OR setting, I'm not sure, but you don't see them very often in ambulance. All right, portable mechanical ventilators, just know that they would be a supplement to a long haul bagging. As far as settings, things like that, you don't need to know a lot of the settings and things right now. Your particular agency would probably give you some information on that, okay?